medicine and neurology in Montreal, Canada, followed by neuro-oncology training at the MD Anderson Cancer Center in Houston. And he's been a member of Mayo Clinic staff since 1999, where he was section head for the neuro-oncology practice and involved with multiple research activities. He's also given numerous presentations for the ABTA. So again, thank you so much for joining us. Dr. You may now go ahead and begin your presentation.
Wonderful. Jennifer, thank you so much for inviting me to do this. And Jennifer, can you see my slide just to make sure I did load it properly, the one that says Understanding Non-Malignant Brain Tumors?
Yes, sir. You are good
Perfect.
to go.
Okay. Well, thank you, everybody, for joining in. I was going to take about 35 minutes to go over a brief summary of this topic of non-malignant brain tumors. And I already looked at the list of questions that were submitted prior to this webinar. And I think you'll find a lot of the questions will be answered during this session. And if there are unanswered questions, of course, we'll have time to go over them as well. Now, as Jennifer indicated, your scan shows a tumor. What's next? And it's hard for patients with malignant brain tumors, understandably. And there's this misconception, as many of you are well aware, that a non-malignant brain tumor probably just isn't as bad because it's not malignant. But it's still serious nonetheless. Why else would you need all these doctor's appointments, multiple scans? Sometimes you need a surgery. And there's a lot of questions like, well, why does one patient need an operation? Others are on the wait-and-see approach and so on. So I would say navigating the field of non-malignant brain tumors is actually probably, for the patient and for the physician team, probably more challenging than is a malignant situation where it's crystal clear. You got to do this, then you got to do this, then you got to do chemotherapy. So we're going to start with this slide here. You've just been shown a scan that shows a tumor, and which way do you go through this big maze of medical appointments and options? So there's various treatment approaches that we'll discuss for several non-malignant tumors. One, of course, is the surgical option. The other one is radiation. And there's various types of radiation. Many submitted questions about standard versus gamma knife versus IMRT versus proton beam. And there's probably even an emerging role for chemotherapy as well. And I'll try to touch upon all of these in a practical manner. So these are the top 4 or 5 questions that I'm often asked in clinic when it comes to non-malignant tumors. And we're going to use this as a template for discussion. Number 1, if it's benign, why do I even need to see you? Or you're the 4th doctor I've seen. One said, let's wait and see. The other said operate. The other said radiation. You're going to be the tiebreaker. Can you guys not agree on one thing or another that's right for me? What about gamma knife? That's what I'm here for. I don't want to talk about anything else. And I've tried all of the above. Do you have any chemotherapy options for my condition? So let's start with this one. If it's benign, why do I even need treatment? Well, the reasons to treat even a non-malignant brain tumor are threefold. Number 1, it's causing you symptoms. A benign tumor, simply by taking up space in your brain, will cause pressure and lead to either weakness, coordination difficulties. Some of you presented with seizures. You know, your skull is a hard bone. It's not going to expand to accommodate a growing tumor. So as the tumor gets bigger and bigger and bigger, it'll slowly start pushing on the path of least resistance, which are your innocent, normal brain cells. The skull will not give at all. Or it's not causing you symptoms yet, but when we look at the scans, we're actually surprised you don't have any symptoms. So we're convinced in the very near future you are going to get symptomatic. So why wait until that happens? We should do this more deliberately and calmly when you can decide if next month is good or 2 months from now is good and so on, rather than waiting until you get to the emergency room. And the tumor is already really, really big. So here is a situation that I encounter a lot. A tiny little tumor, and you can probably see my mouse cursor. There's a little tumor there in the front of the head, and if we look from the side profile, here it is here. And we think that this is a meningioma, a tumor that arises from the meninges, which is the covering over your brain. If you think about your brain as being wrapped in a plastic wrap for waterproofing purposes, that waterproofing saran wrap is meninges. So if that wrap forms a tumor, we call it a meningioma. So the tumor indents the brain from the outside in, much like the way a fist indents a balloon. Now, here's a 68-year-old patient, a small tumor. The person was involved in a car accident, a teenager rear-ended him, and this tumor was found. And so it's clearly asymptomatic. And what should we do? And also, I indicated this patient is 68 years old. Does age matter in addition to the fact that it's small and asymptomatic? The answer is yes. The reason for that is because when you deal with a slow-growing tumor, we're dealing with a turtle. Fast-growing tumor would be like a rabbit, and we all know the story of the rabbit and the turtle. The turtle can actually win the race if we don't pay attention to it. So the rule of thumb for a benign or non-malignant tumor is that just because it's a turtle, we shouldn't be like the rabbit and just fall asleep at the wheel and stop paying attention to it, because it may really get ahead of us if we don't follow it up every once in a while. But if you look at a 68-year-old patient with a meningioma, that patient, let's say, has 20, 30 years of life ahead of him or her. In that time frame, that small tumor will probably grow just a little bit compared to in a younger patient. So when is it worth the risk of an operation? Here's a 20-something-year-old guy I've been following for some time now. He has a tumor called SEGA. It's a very, very slow-growing astrocytoma, subependymal giant cell astrocytoma. And here it is in the very, very deep portions of the brain. And this was in 2006, but even scans predating this by many years show that it was the same size. And you can see that if you come this way, or this way, or this way, there's just no way to get at this tumor without accessing a lot of normal brain that's in the way. So understandably, we told the patient, look, it's not causing any symptoms as yet, and it's very, very slow growing. We're going to keep an eye on this. But if it starts to grow or cause problems, then we'll intervene. And then in 2008, a couple of years later, his tumor grew and actually seeded this area as well. And he started to get hydrocephalus, meaning the fluid-filled compartments in his brain started to get a traffic jam because the fluid has to drain through a lot of canal right about here. And that incremental growth of the tumor clogged up the canal, and it's the canal blockage that led to the fluid buildup that caused the patient to have more walking difficulties, balance issues. So he was clearly symptomatic. So a surgery was warranted. And our neurosurgeon in chief, Dr. Meyer, did this operation. And if you look at the post-operative scan compared to the preoperative scan, I think we would all say this is a wonderful job. It's victory, isn't it? But of course, many of you are asking, what does the patient look like? Well, he had an extensive rehab. He had to spend about a month in the inpatient rehabilitation facility, and then even at home, really a lot of PT, OT that he needed for another 2 or 3 months before he could get back to the way he was. So, 2 weeks in the hospital, then 4 weeks in rehab, then 2 more months of rehab at home. The road to recovery was a long one. And so you can see why, for deeply situated tumors, that unless we really have a good reason to proceed, we'll leave the patient alone, because we have to be able to justify that risk that the patient will take to achieve a scan that looks like this. Now here's a gentleman who has a very large tumor in the cerebellum. This is again a meningioma growing from that wrapping over the brain called the meninges, pushing the brain like the way the fist indents a balloon from the outside in. It's very large, and I said in the introduction of my talk that if it's very, very large, we probably should do something. Well, but he had no symptoms. He was found to have this tumor because he fell on ice. He didn't put salt on his front steps, slipped, hit his head. His friends are all firemen, so they whisked him off to the hospital, and they did a CT scan to make sure he didn't have a bleed or a broken skull. The answer was good news to all of that, but they found this big tumor. And the patient was this really stubborn guy. He just simply said, look, I didn't come here looking for a tumor. Since I don't have a fracture, I'm fine. I want to go golfing because I'm retiring now. I don't want surgery. And he crossed his arms and looked at me with a frown. And I told him, well, not just because he doesn't want a surgery, we didn't have a good reason to put him through it. He has some other medical illnesses too, and this was found purely by accident. But we told him, look, at the very least, though, you have to guarantee that you'll let us get a scan on you every once in a while, so that if this starts to grow without you even being aware of it, then we get a heads up to do something. Well, that was 2001, not long after I joined the Mayo Clinic staff. In 2011, even with a scan that was received not that long ago this year, this tumor has not grown over the course of more than a decade. So the tumor size is important, but it's not the only factor in the decision. If we know that a meningioma tends to have the growth pattern that's very, very slow, we can give the patient the benefit of the doubt and say, well, look, our hand is not yet forced. Let's see what this tumor does on surveillance, and then act if it causes trouble. So the deciding factors of treatment would be, well, first and foremost, size. Large tumors have more cells, and they're more likely to cause symptoms. But the tumors can grow very, very slowly. So more important than size is it causing symptoms? And if it's not causing any symptoms, it's perfectly reasonable to wait. And this is why patients will often come with a scan that looks like this. One colleague in the field said, oh, we got to do something. Another one said, well, maybe we could take a wait-and-see approach. Or another one might be wishy-washy and ask the patient, well, what do you want? We'll just do what you want to do. That's the worst approach, of course. We should recommend a course of action. Location, very important. Right here where that arrow is, there's a big, huge vein that ultimately drains to become the jugular vein that goes through the neck and takes the blood from the brain back to the heart. So if a surgeon were to operate, the fact that it's near a large vein would mean they can't get it all out, but because it's in close proximity to a blood vessel, there's a risk of bleeding and a stroke. And again, with anything in medicine, whether it's brain tumors or a pneumonia or a foot infection, do the treatment's benefits exceed the risks? And only when we are convinced that the benefits outweigh the risks that we would proceed. Age is important. I don't want you to think that we don't operate on patients past a certain age, but going back to that rabbit and turtle analogy, how long do we expect this patient to live? If you have an 85-year-old gentleman with many other medical illnesses, chances are he's not going to have 20 years ahead of him. And it matters because if this tumor was diagnosed in a gentleman, he was 65 when it was diagnosed, just as he was retiring. He's now 75, and at the risk of 65, that's the age of 65 with some other medical illnesses, he had a fairly high surgical risk. We left him alone because it wasn't causing symptoms at all. But at his age, the risk was kind of high. Now that he's older, the risk is even higher. So you might argue, well, did we miss a window of opportunity? Well, time would tell us we did not because it hasn't grown at all. So age is important. Symptoms are important. The risk of the surgery, which is somewhat age-dependent and location-dependent, and, of course, other medical illnesses. And very importantly, what's in it for me? Me being the patient. Will I, the patient, feel better because I get an operation or something done? And in this gentleman in particular, he was asymptomatic. So we can't make him feel any better than he is now. He's otherwise doing very well with exercising and playing golf regularly. Will the treatment avert some sort of a catastrophe? Well, no. As long as we keep a close eye on this gentleman, we're not going to miss a window of opportunity to do something in a deliberate manner. Or it's a good enough reason to operate that it'll just make the scan look better. And of course, that's not a good enough reason. The scan's important, but the patient who owns that scan, that brain, is far more important. Let's go to the next question. One doc said wait and see, the other one said operate, the other one said radiation. Can't you agree on what is right for me? And we're often serving as the tiebreaker when the patient comes here for the appointment. So here's one of my patients. She has a condition called NF2, neurofibromatosis type 2. It's a genetic condition that predisposes to a multiple benign tumors, schwannomas, meningiomas, and in this patient, she had tumors on both sides of her brain. Here's a nerve that's going to her right ear. We're looking from underneath. So this is a vestibular 8th cranial nerve schwannoma on her right side. And here it is, a mirror image on the left side as well. And this is very characteristic of NF2 patients. Well, we have two tumors. One of the questions is, which one should we target for therapy? Well, she's losing hearing on her right side. And she's actually to a point where she cannot use a telephone there at all. She can't understand speech. I mean, she can hear sounds, but there's really no functionally usable hearing left on that side. That actually helps us in the neurosurgical team, because if this ear right here has no usable hearing, then taking that tumor out through what's called a translabyrinthine approach, which actually affords the best likelihood of getting most of this tumor out, would probably be very appropriate for her, because we can get as much tumor out as possible, but also this surgery will guarantee she'll have no hearing at all on that right side. Well, the fact that she can already understand no speech on that side, it won't impair her quality of life anymore as a result of the surgery. What if the hearing was good on both sides? Then what? Well, the right one was actually starting to grow. So you should target the one that's starting to act up and maybe will cause trouble in the near future. And if hearing is still present in a usable manner, then the surgical approach changes as well. A surgeon might say, well, let's take this terional approach, which simply means the surgeon comes in at an angle that may be permissible to try to preserve the hearing in that ear. And also, what about that left one? Okay, it's there, it's not growing, and it's asymptomatic. Well, you know, that one, we could take a wait-and-see approach, because maybe it'll grow in 6 months, maybe it'll be 6 years before it starts to grow. So why expend a bullet when we probably don't have to for the time being? And sure enough, 2 years later, the right one grew back. We gamma knifed it. 2 years after that, this one that was staying put for altogether 4 years in total started to grow, and the hearing started to come down as well. So the patient had a surgery on the left one, but now we have a patient who's already deaf from this tumor and has taken this tumor out, and the patient's deaf as a result of that surgery. We have a completely deaf patient. The scan looks better, but everyone would agree her quality of life is bad now. So auditory brainstem implant. Take something away, try to give something back. The patient had an implant placed by our skull-based neurosurgeon that actually allows, with some degree of lip-reading knowledge as well, to actually converse. And it can be quite effective if you have the correctly motivated patient who's able to learn this and also go through a surgery like that. So this is a very complex situation, 2 tumors, 1 on each side, and the decision-making process that went into it included which one was growing, which one was still associated with usable hearing, and should we use surgery or a gamma knife, and if we end up with a deaf patient, is there some way we can give back some quality of life through this auditory brainstem implant? Now, this is a question we get every day in the clinic. Gamma knife, that's what I'm here for. This is actually the precise words that I hear from patients almost on a daily basis. Now, gamma knife is the trademarked name by the Lexell Corporation. The generic term would be stereotactic radiosurgery. So gamma knife is one brand. You also hear about CyberKnife. You hear about Linac. They all basically mean the same thing. It's very focal beam of radiation, and the reasons we use them are the same no matter what brand technology that your hospital may have. So let's talk about that. So here's SRS, stereotactic radiosurgery, and in this instance, the gamma knife format, so to speak. Here is this target somewhere in the brain of this patient, and if you look at it, each individual beam of radiation coming into that target, there's probably about 20 or 25 beams coming in. But each individual beam is actually of no use at all. It's too low of a dose. It's too wimpy. It really won't do anything to the tumor. But if 20 or 25 of these individually useful beams converge simultaneously on one target, now you have a lethal kill zone. And it can be very, very effective. Imagine, another way to think about it is this poor tumor is tied to the pole of a firing squad. Each one of these firing squad members has a rubber bullet, and the rubber bullet will sting, but it's not going to kill. But if 25 rubber bullets hit on the same part of the target at the same time, you have a lethal damage there. And that's basically what in a nutshell, stereotactic radiosurgery represents. Now, what's the poster boy or the poster girl tumor for this technology versus a full-blown operation? So for SRS, we have a tumor that's ideally a sphere. It's just a little ball or a marble in there. The tumor ideally would be about 2.5 centimeters, or in non-metric terms, about an inch or less. Beyond that, the risk of radiation swelling starts to go up quite a bit. So that's why there's a cutoff. And also, very importantly, this is very intense radiation, as I discussed, and therefore, we want that tumor to be not touching a vital sensitive nerve. For example, the ability to see is important for all of us, the optic nerve. What about the hearing nerve or your pituitary gland? So you can have a spherical tumor, the correct size, small enough, but if it's right smack dab touching one of these important nerves, then we would not be able to do that treatment. What about surgery? Well, if you have a tumor that's very, very easily accessible to the neurosurgeon, then surgery would be a very good option. You have a patient who's very healthy, and therefore would tolerate the anesthesia without any difficulties at all, a young patient. This is important because what if you have a 72-year-old woman with a meningioma? It's about 2.5 centimeters, but she has no other medical illnesses, but she tells me everyone in her family died at 80, and she expects to do the same. Not to say we'll hold her to it, but 5, 10 years of life expectancy. If we give gamma knife with this SRS technology, we're talking about maybe 10 to 15 years or more of tumor stabilization. So for that older patient, it may actually be the best choice because, one, it's very convenient. Two, the longevity or the duration of the treatment benefit fits her age very well. Contrast that to, say, a 25-year-old. At 25, what if that patient has 50, 60 years of life ahead? When the gamma knife or SRS benefit runs out in 10 or 15 years, that patient is still younger than me. And then what do? We can operate, but probably for a younger patient, we'll operate first. Not previously irradiated. And that's a comparison between SRS or surgery. What about comparing SRS, stereotactic radiosurgery, versus the conventional way of giving radiation, otherwise called fractionated radiation? That's when you get radiation Monday, Tuesday, Wednesday, Thursday, Friday, rest Saturday, Sunday, and then repeat Monday, Tuesday, Wednesday, Thursday, Friday, Saturday. Whoops, Monday, Tuesday, Thursday, Friday. So 5 treatments a week altogether for 5 or 6 weeks. I think everyone would say, geez, if I had my choice, I'd rather get this one-day treatment compared to a 6-week treatment. But it depends on the kind of tumor and where it's located and size. For example, if you compare what are the differences between these two technologies, imagine if you had a very light dumbbell in the one arm and the same dumbbell in the other arm. Fractionated radiation would be like doing 60 arm curls with this very light dumbbell over 60 minutes. And I think everyone would say that's pretty easy. That's 1 arm curl a minute. And you can do that watching TV, watching a Packers game, or here in Minnesota, Vikings game, and your arm will not be sore the next day. Now, stereotactic radiosurgery, on the other hand, would be like doing 60 arm curls, but over 1 minute. So that's 1 curl every second. Now, it's the same amount of work. Work is weight multiplied by distance, but divided over a much shorter time period, so it's much more intense. So if you imagine doing 60 arm curls with a 3-pound dumbbell over 1 minute, your arm's going to be pretty sore the next day. So similarly, SRS actually does have a higher risk of radiation-associated injury, such as a swelling that could occur a month or so thereafter. Size and location matter. Here's a tumor that's about 4.4 centimeters, maybe about 1.75 inches. It's too big for SRS, the limit being about 1 inch or 2.5 centimeters. And look, here's we're looking from underneath. Here's the left eye. Here's the left optic nerve. This is the cable that connects your retina to your brain so you can see. And that cable is somewhere going through this mass. So stereotactic radiosurgery or gamma knife will hit this region and the optic nerve with a very intense radiation, and the very thing we're trying to preserve, which is vision, we may end up hurting it. It's also wrapped around an artery. Here's an artery there, here's an artery there, and there's other nerves going through this region as well. So if radiation in the way of gamma knife is difficult, well, operating here would be not just a challenge. I think to do a meaningful surgery for a tumor like this would be very, very difficult without undue risk of neurologic injury risk to the patient. So this patient was actually treated with fractionated radiation, that Monday through Friday treatment, 5 treatments a week for altogether about 5 or 6 weeks. And the patient didn't like it because it was very inconvenient. However, it was the right kind of treatment because of the patient's tumor size, the location, and the fact that we just could not get at this in a meaningful way by way of an operation. And 2 years out, this tumor is not grown. Patient's still doing very, very well. Now, how about this tumor? It's small enough for gamma knife, but again, it's still too close to the optic nerve for us to hit it with an intense radiation called gamma knife or stereotactic radiosurgery. Since 2005 of original discovery, we've taken a wait-and-see approach. In July of last year was the last visit, and doing well. In fact, I saw this patient back just July of this year as well, still doing well. But slight growth, but still no symptoms. He's 79 years old, golfs, plays with grandkids, is happy. Now, I said that it grew. Isn't that a good enough reason to treat? Well, he feels just fine, and it was a very incremental growth, about 1/10 of an inch, and he's still not having any symptoms. And a very important thing to realize about non-malignant tumors is that just because it grows on one scan, it does not mean that the horses are out of the barn or out of the corral. They're not going to grow like gangbusters. They grow, and then they can go back into dormancy or sleep for months, if not years sometimes. So for this gentleman, we're going to continue to take a wait-and-see approach, and I wouldn't be surprised if the next scan shows that after that incremental growth, it has gone back to being stable. What about this? A less touched on topic, don't you have any chemotherapy for the non-malignant tumors? Well, let's talk about this lady. Here's a lady with a condition that we think she inherited from her mother or father, probably a genetic predisposition like neurofibromatosis type 2 that increases the risk of meningiomas and schwannomas and other low-grade, slow-growing tumors. And if you look at her scans, just look at how many tumors. In fact, each time I go through her scans and try to actually count the individual tumors, I come up with a different number because, as the title indicates, there's just really too many tumors to count. And if you look from a side profile, 1, 2, 3, 4, 5, 6, 7, and that's just one slice of the brain. And the tumor burden in the brain is so extensive, it's actually pushing the entire brain downwards to a point where this part of the brain, which is supposed to be above this line that separates skull and spine, the brain's actually pushed through this orifice. Look at it face to face, you can see again the extensive tumor burden. It's a very crowded brain. And she even has a tumor in her spine here, and also down the thoracic spine. This is about the chest level. None of these, believe it or not, are causing her any symptoms. Now, should we consider chemotherapy? I mean, I think everyone would agree, looking at these scans, how many operations would she have to her head to get rid of all these tumors? Well, if I can't even tell you how many tumors there are because there's too many to count, then that's not a surgery worth doing. Will hurt the patient, of course. So surgery is not an option. Radiation, well, if you look at that, how many gamma knife radiations can we do? She'll be in the gamma knife machine for weeks on end. How about fractionated radiation, that Monday through Friday for 6 weeks? We'd have to give pretty well the entire brain radiation. And for this lady who was running half marathons and cycling and racing and just one of these super athletic people, would I actually help her by putting her through all that? No. And that's why we come to the question in her, well, what about chemo? And that's why she was sent from her doctors after many other institutional visits. Surgery is not an option. Radiation is not an option. We agreed. They wanted to ask us, what about chemotherapy? Now, in favor of chemo, there are so many tumors. We cannot operate on them all. We cannot give radiation to them all. So let's hit them all with chemo by mouth or by vein. The chemotherapy gets into the bloodstream, and we should be able to hit everything that we see. Sounds good, sounds reasonable, but there is no truly proven chemotherapy for these non-malignant brain tumors. What about this? We get asked this a lot. What about angiogenesis inhibitors? Many of you have heard of a drug called Avastin or bevacizumab. It inhibits the tumor's ability to recruit in blood vessels, and it's been effectively used in many malignant tumors. Why not then import its use into the realm of benign brain tumors? Well, unanswered questions. First of all, for how long should we use it? Should we use it indefinitely on this patient? They are side effect prone, like bleeding in the head, clots in the leg, clots going to the lungs, high blood pressure, and so on. So there's a question about safety of long-term treatment. And again, for how long should we use it? Indefinite is not acceptable. So for her, we have taken a wait-and-see approach. She's still not needed in treatment as yet. And for those of you who have wondered what Avastin is, or otherwise called bevacizumab, it's an antibody that inhibits angiogenesis, meaning the recruitment of new blood vessels. So if this is a tumor, the tumor secretes a compound called vascular endothelial growth factor. Think about it as throwing a football to the wide receiver. That football lands at a thing called VEGFR, which is a vascular endothelial growth factor receptor, and it is on the blood vessel a certain distance away. Once it docks here, it brings the blood vessel to the tumor, bringing in supply lines with oxygen, nourishment to sustain and increase tumor growth. And bevacizumab or Avastin blocks this, meaning like an interception during the football play, so that it doesn't get received over here, and the blood vessel regresses. And therefore, the tumor should either stop growing or maybe even shrink. But let's forget the expense. There is a risk of a clot. There's risk of bleeding. And again, we have no idea what's the optimal duration of use. And again, indefinite is not an acceptable option. So we go through some questions as well. But I think the theme that I try to present here is that one size does not fit all. For people 40 years or older like me, this is Will Chamberlain, who was once upon a time a basketball hero. He's, I think, 7 feet 4 inches tall. Here's Willie Shoemaker. I'm sure they have different tailors. They don't shop at the same place, I'm sure. One size does not fit all. In any aspect of medicine and surgery, it comes down to a balance. Do the benefits outweigh the risks? And if that's the case, and we have compelling data to say that's the case, then we'd recommend the treatment. So with that, open up the field for questions. And just to let you know that I live in Minnesota now. Here are the Vikings. And that's Nadia Locke, who's one of our best radiation physicians. There's Ian Parney, a superb brain tumor surgeon out of 15 colleagues who operate on tumor patients here. And since I made the slides, I took the liberty of putting myself in the middle as the quarterback. So thank you, everybody, for your attention, and I look forward to answering some of your questions now.
Wonderful. Thank you so much, Dr. We have lots and lots of questions to get to, literally dozens of them, so we will do our very, very best to try to get to as many of your questions as possible. So we'll start with the first question, which asks, how many times can the brain be safely radiated?
Right. In fact, probably the more accurate question would be, what's the cumulative maximum dose of radiation that a normal brain can tolerate without undue risk? And so, how quickly we get that radiation is important too. You know, many times we tell a patient, look, radiation is really a one-time deal. We'll be able to give it this time, whether it's gamma knife or the fractionated format over 6 weeks, but we do not foresee being able to give more ever. Well, we never say never, right? If you got a certain amount of radiation, but that was just a year ago, repeating the radiation so soon, the normal brain around the area of radiation really have not recuperated from the radiation. It would be like, Jennifer, you go to the gym, you've had this incredibly tough workout, and you're a real fanatic, so you worked out in the morning, you're going to go again in the evening. Well, you're going to get a tendon injury eventually, aren't you? But if you rested 2 or 3 days after your workout, you're ready for the next one. What's the rest period that a person can undergo before we can actually give radiation once again? You know, there's no perfect magic formula or mathematical number, but if a person's radiation was 7, 8, 9, or 10 years ago, and the tumor starting to grow back, we can actually make an estimate as to how much of that original radiation has a normal brain actually kind of forgotten about and recuperated from, and then top up the dose, so to speak. So if enough time has elapsed since the last radiation, we would actually consider repeating the radiation if we don't have other viable options. Have we ever done radiation 3 times or more to the same target? In my own practice, I've never done that. So I think we could consider repeating it once if enough time has elapsed and there's no other treatment options available. But the 3rd or 4th or 5th go around, no, that would not be a good idea.
Okay. The next question comes from Kathy, and she asks, does having a meningioma predispose you to strokes?
Not the meningioma itself. Meningioma, as I said, is a tumor that arises from the covering over your brain. And these meningiomas, you're probably asking that, Kathy, because characteristically, if a meningioma is near an artery, it likes to do a little bit of a bear hug embrace on that artery. And the artery can actually become a little bit narrower. Fortunately, we're not even aware of a single patient where the artery ever got occluded, so the person had a stroke. So it kind of embraces the artery, but it won't choke it off altogether. So the tumor itself will not predispose to a stroke. However, what if I gave you radiation to that tumor? Well, within the tumor and around it, the little blood vessels are aged a little bit more rapidly. Kind of like if you went suntanning a lot when you were a kid, you're going to have more wrinkles as a result of suntanning, which is radiation from the sunlight. The same thing happens in the brain when we give brain radiation. So not the tumor itself, but sometimes the treatments we give to that tumor, like radiation, that can increase the likelihood of a stroke. It doesn't mean that you'll have one. It just statistically increases the likelihood.
Okay. The next person asks, if the brain and bone are invaded by the tumor, is the outcome worse? Moreover, what are the chances of it growing back?
Right. So meningiomas come in 3 varieties. One is the most common variety, which is the grade 1, otherwise called benign. The grade 2 is neither benign, but it's not malignant either. It's just a little bit faster growing, and when we look at it under the microscope, we can see some cells undergoing division. Grade 3 is otherwise called a malignant meningioma, and as the name implies, it's very rapidly growing, and it's capable of local tissue invasion and destruction, including the bone and the underlying brain. So that question is pertaining to a malignant meningioma, which by definition has a much higher likelihood of coming back, and therefore, rather than just operating and saying, well, surgeon got it all, we don't see any residual tumor, we're going to have to assume in that patient that there may be some microscopic tumors. So in many instances, the physician would say, let's try now radiation to go after the stragglers that probably were left behind by the surgeon. And in that instance, we even consider doing a chest X-ray or a CT of the chest, because unlike standard meningiomas that never go outside the brain, a malignant meningioma can even metastasize. So is it a more serious disease that's prone to growing back and even going to other organs? It is, but it's also treatable if you catch it early, do an extensive surgery, and treat it with radiation sooner than later.
Okay, thank you. The next question is, can brain tumors cause seizure activity in other parts of the brain?
Right, so seizure is basically your brain doing something when it wasn't supposed to. So when you wave hi with your right hand, a certain part on the left side of the brain that controls the right side fired an electrical impulse. but you did that willingly because you wanted to wave hi or goodbye. What if that part of the brain fires an impulse when it's not supposed to? You'll get this jerking movement of the hand that you did not want to do. If that jerking electrical activity spreads to other parts of the brain, your whole brain seizes, then you lose consciousness and you convulse on the floor. So seizure can occur when a brain tumor, benign or malignant, basically presses upon the brain wiring. And after a while, the brain wiring is going to just say, that's enough. I'm going to complain. And you can imagine a complaint as being a seizure. The brain saying, I've had enough of this. Some patients can get a tumor that's very large. They never have a seizure because it grew so slowly. And others, they have a seizure when the tumor is so relatively small because some parts of the brain are actually easier to short circuit into a seizure than others. For example, temporal lobe, much easier to make into a seizure. Motor cortex, but you go to the frontal lobe or the parietal lobe or the occipital lobe, those areas can be made to have a seizure, but they have a higher threshold. So the answer is yes, a tumor can induce a seizure. It depends on location and also the size of the tumor and also how quickly is that tumor growing.
Thank you. The next question comes from Gloria, and she asks, what exactly is a subependymoma and will it continue to grow?
Right. So let's talk about ependymoma without the prefix sub. Ependema, this origin of the ependymoma tumor, there's a drainage canal from your brain all the way to the tip of your spinal cord. It's called a central canal. And this canal is lined at the banks by cells called ependema. So if they form a tumor, you have an ependymoma. And they tend to occur at the middle of the spinal cord or in the very deep portions of the brain where there are fluid-filled compartments. They tend to be almost always very slow growing, and they're often classified as benign tumors. Now, a subependymoma is a classification for an ependymoma that is even slower than the typical ependymoma. So it's better to have a subependymoma than it is to have an ependymoma. However, because of where they occur, it's often difficult to get them out completely. So there's a leftover tumor. Eventually, yes, with enough time, they can grow back, but it can be years sometimes before they do anything. But if you have enough life expectancy left in you, could this tumor grow in your lifetime? Yes, it will. Will it cause you symptoms? Only if it gets big to a certain level.
Okay. The next question is with regard to meningiomas, and the person asks, or says rather, that there isn't enough information about meningiomas, and she'd like to know if there are other people like her. And I just wanted to take a moment to mention that the ABTA does have an online support community called Connections. And if you visit our website, it's a wonderful, basically like an online support group. You can interact with other brain tumor community peers. It's a great way to get support and inspiration from the convenience of your own home. So if you haven't yet checked that out, I would certainly encourage you to do that. But the next question states, I have developed scar tissue since surgery roughly 5 years ago, and it's causing seizure activity. Will it continue to get worse? And then the second part of the question is, in addition, since that surgery, I have memory deficits, cognitive issues, and fatigue, and will that ever go away completely?
Right. You know, I wish I could tell you, yep, it'll go away. You just got to wait long enough. And I think you're probably rolling your eyes if I would actually tell you that, because it's probably already been a while since that surgery and since you've started on seizure medications. And so, again, cognitive difficulties, energy level changes are also largely dependent upon where in the brain the surgery had to be done. Some parts tolerate surgery beautifully. Other parts are much more delicate. And even with the most meticulous of surgical hands, taking out a tumor is traumatic to the brain. So number one, the scar tissue, the tumor causes some scarring, but so does the surgeon's scalpel. And scar tissue in and of itself can predispose to a seizure. And in fact, the #1 cause of seizures in the world are actually not due to brain tumors. It's due to scar tissue caused by whatever injury to the brain. Now, a scar tissue induced by a surgeon was done because it was necessary. The risks were outweighed by the benefits. But it can short-circuit the brain to have a seizure, and the seizure medicines go into the brain and actually corral in the unstable areas so that the instability doesn't spread to other parts of the brain, so you have a generalized seizure. But two things. #1, the area of the brain that had to be operated on probably led to some of your memory and cognitive difficulties. And to somewhat add insult to injury, the absolutely necessary seizure medicines to protect you from the seizure, well, they come with a price tag. They almost always contribute to some degree of fatigue and short-term memory difficulties as well. And there's that double-edged sword. What I and your physicians are telling you is that we don't want to give you fatigue and more memory trouble with the seizure medicines, but you have to do this, otherwise the seizure is a worse thing to have. And getting back to your final question, will those ever completely go away? I don't think so. You know, if they've been with you for more than about a couple of years, the chances that they'll completely go away, unfortunately, are very, very low. But one of the things you should ask your doctor about, and he or she have probably already raised it, is, look, if you can't get me off the seizure medicine, are there seizure medicines that I can try that are, A, less likely to cause me drowsiness, something in your control that you can manipulate? And is it worth trying a different seizure medicine? If your seizures are under pretty good control, they may consider that. Or, okay, I'm on the seizure medicine, third one, and this one really is less fatigue-prone than the other two, but I'm still kind of tired. Can I try a stimulant kind of a medication to kind of boost my brain function, like Ritalin, methylphenidate, Provigil, things like that? And you might say, well, that's yet another pill I have to take, but it could sometimes help improve your quality of life.
Thank you. The next question comes from Becky, and she asks, is there any risk that performing a biopsy will cause metabolic acceleration to a cerebellar tumor?
Right. It's a good question. The honest answer is nope, not at all. I get asked this question at least once a week. Once upon a time, there was medical literature theorizing that touching a tumor, operating on it, exposing to the outside environment is like awakening a sleeping giant. That if you disturb it, it's going to now grow like gangbusters. You know, there just simply is zero data to support that. So if you need a biopsy or you need a surgery, the factors that you need to be concerned about are the risks of the operation itself, the anesthesia, bleeding, stroke, etc., but not the risk that is going to awaken a sleeping giant.
Okay. The next question comes from Shannon. And Shannon asks, do you believe that children diagnosed with benign brain tumors have long lives ahead of them?
Yes, it really depends on where the tumor is for the most part. Because, you know, if you have a child with a tumor called juvenile pilocytic astrocytoma, that's a benign tumor. And we call it juvenile because it tends to occur more often in kids than it does in adults. But let's say your child's tumor is in an extremely easily accessible location to the surgeon. Surgeon gets it up in the right frontal location, and I think we'd be able to tell that child and his or her parents, you know, we may never hear from that tumor ever again. Contrast that with that same tumor occurring in a very, very deep location in the brain, and if we can't get it out, then we're going to have to say eventually we'll probably have to do a radiation. And then what are the risks of that to a growing child's brain and the evolving brain? So in certain circumstances, yes, a child with a benign brain tumor can have a completely normal quality and quantity of life.
Thank you. The next question comes from Danielle, and she asks, how often is it okay to do a wait-and-see approach when you haven't biopsied the tumor?
Right, and that's a very good question because, you know, when you come to our offices, we're all dressed nicely. We put up our awards and degrees on the wall. So you are coming to our home court with our home court advantage. And if we tell you, trust us, we're a physician team, we're going to take a wait-and-see approach, we have to have you leave our offices being reassured as to why that's the right approach. And you're absolutely correct, except for doing a biopsy or surgery so we could take a piece of it and look at it under the microscope, we can never be 100% certain that that tumor is benign or what we think it to be. But let's talk about a meningioma, for example. Meningioma, we've been burned a couple of times. We tell the patient, hey, that's meningioma, or we think that's what it is. But we always tell the patient after first discovery, let's get the next scan in 3 to 4 months. Now, if you look up meningiomas, you'll see that often we'll scan the patient maybe once a year, once every year and a half. But after first discovery, just like this person is asking, what if we're wrong and it's not a benign tumor? Well, time. Time is always a tiebreaker. 3 months goes by, it's not grown. So we do another scan 6 months later, it's not grown. 4 years have gone by and it's not grown. So we cannot be 100% guaranteed that this is a meningioma, but we can 100% guarantee it's a benign tumor, and most likely a meningioma. So time is often the best tincture.
Thank you. The next question comes from Sardana, and she asks, how much radiation do the MRIs give?
Oh, right. Well, MRI does give off radiation, but it's magnetic radiation rather than ionizing radiation. And the kind of radiation that all of us need to worry about in terms of our health would be what's called ionizing radiation. These are the types of radiation that go in and cause unstable oxygen molecules, which then go on to hit the DNA, which then go on to either kill a cell, and that's the way radiation kills tumor cells, or if you suntan too much, you might get a melanoma. It could initiate tumorigenesis. So CT scanners, X-rays, the kind of radiation machines we use to treat tumors, those are ionizing radiation. MRI scan uses electromagnetic radiation. They call it radiation because it fits the physics term, but it's not radiation in the way that you and I and normal people actually worry about. Radiation simply means wave forms, and ionizing radiation is a very high energy compound that can break DNA and so on. But to answer your question through a long answer, magnetic radiation does not damage your DNA. And as far as we know, now how many times have you heard this before? But as far as we know, MRI is not dangerous to the patient. In fact, let's say we had a pregnant woman who has something going on and we need to scan that patient, we would always use an MRI and not a CT scanner, because a CT scanner is DNA damaging. We could damage the baby. That's an evolution. With the MRI, as far as we know, the pregnant women who get those scans, they're not at any higher risk of having a malformation.
Thank you. We have just a few more minutes remaining for questions, and we do have quite a few left, so I will apologize in advance. We won't be able to get to all of your questions. But the next question asks, what does the latest published research suggest about the efficacy of new and potentially breakthrough treatments other than surgery or radiation?
Right. You know, and I think that's probably a veiled question. Another way to ask it is, how come there's not as much breaking signal transduction, new drug development for benign tumors as they are for malignant tumors? And one is sense of urgency. But you know, what's good is that what we learned from the treatment of malignant counterparts of tumors, we can sometimes import it into benign tumors as well. A recent publication about low-grade gliomas or high-grade gliomas, like glioblastoma being treated with radiation and chemotherapy together rather than radiation alone. Well, the most recent data would indicate maybe it's a good idea to do the radiation chemo together, even in low-grade tumors. So sometimes the knowledge we gain from high-grade aggressive tumors, it actually does come downstream to the lower-grade tumor populations as well, including benign brain tumors. But you're right. One of the limitations of doing cutting-edge research on benign tumors is that benign tumors don't grow well in a dish. So we can't study them outside the brain very well. So we can't test interesting new drugs as easily on them as we can in fast-growing tumors that grow on a dish. And fast-growing tumors also grow in the brains of animal models. So we can test it in animal settings. A meningioma is excruciatingly difficult to grow in a dish or in an animal model. And therein lies one of the limitations of research in this area. It's great that they're benign tumors, but the fact that they're benign lends themselves to be a bit more difficult to study.
Thank you. We do have one last question. Well, we have lots of last questions, but the last one that we're going to answer right now. The person says or asks, after surgery and radiation 15 years ago, my tumor is growing back. Does that make it atypical? And are you able, with technology, to now estimate growth rate or time?
Right. And the answer is no. It does not guarantee the regrowing tumor has now transformed to the next level, grade 2, otherwise called atypical meningioma. The only way to be absolutely certain is to actually take a piece of it or operate, so biopsy or surgery. But, benign meningiomas will sometimes just break through the frontline therapy after a decade or longer. That also brings us to why in a younger patient, we probably would opt more to do a surgery if we had a choice between surgery or radiation, because in 10 years, a young patient is still relatively young. Whereas an older patient who's, say, 70-something or what have you, maybe 10 years would be more than sufficient, because even when it starts to grow back at that point, it'll still grow back, often at a slow rate. But sometimes when it grows back, it can have evolved to the next level. And we can't estimate growth rate based upon one scan. Basically, we plot it like the Dow Jones Industrial and the Stock Exchange. You take multiple time points, and we plot it on a curve. And if it's growing quickly, the curve is steep. If it's growing slowly, it often just plateaus out. So if your tumor's grown back on a first follow-up scan or on a follow-up scan after 10 years or 15 years, does that mean you must panic or get something done? No. At the very least, it means we've got to get the next scan a little bit sooner to see, is this in the active mode, or will it even go back to dormancy?
Okay. Well, thank you so much, Dr. of Mayo Clinic in Rochester, Minnesota. We really appreciate your time today and for your wonderful, wonderful presentation. I know we could probably easily continue this session for probably another hour or so, but we do need to go ahead and wrap up. Someone did ask, though, whether or not this question and answer session is also being recorded and will it be available. And yes, it is a part of the recording. So for folks following the webinar, when you get that link, you can certainly listen to this Q&A portion. But unfortunately, that is all the time that we have today. Thank you so much, all of you, for joining us. We do invite you to continue to check back at our website, which is www.abta.org, for other brain tumor-related topics in our webinar series. We do have a next webinar coming up already. I can't even believe I'm saying that next week is December, but it's going to be next week on Wednesday, December 5th at 12 noon Central Time, so do check your time zones. The presenter is Brooks Kenny of Lots of Helping Hands, and Brooks is going to provide, with the ABTA, a demo of the ABTA's new program called My Caring Link. And My Caring Link is our brand new personalized online tool that allows you to communicate with family and friends at your convenience. And so during this webinar, you'll learn much more about how to set up your own My Caring Link page, program features and how to use them, assigning member roles, and tips for getting the most out of your My Caring Link community. So I hope you'll consider registering for that. For now, however, this does conclude the American Brain Tumor Association's Understanding Non-Malignant Brain Tumors webinar. Again, thank you very much to all of you for participating and to Dr. June Please do be sure to complete the brief survey that you will receive in an email following this webinar, probably within an hour or so. There's just a few questions. If you could provide your feedback, it really does help us tailor the programs to meet your needs.